So let me just open the chat just to make sure. All right. All right, everyone. So we're going to go ahead and get started. I'm going to share my screen. And again, we are doing a next gen question using Bootcamp NCLEX Bootcamp. If you're not familiar with them, highly recommend them. They are great. I have, just to introduce myself, my name is Damaris, also known as Mrs. D. A lot of people like to call me Mrs. D. I didn't come up with that name. People called me that, so I just went with it. But it is a pleasure. I have been a nurse since 2017. I have been educating for quite some time now. I got my master's in nursing education in 2021, and I've been doing that ever since. I have taught in the university as well as the in a healthcare staffing agency where we educated nurses in other countries. And so that was fun. So I have a plethora of experience and knowledge in tutoring and educating on nursing content, and particularly on NCLEX. My background stems from cardiac step down. That's where I first started. It was a great floor. I loved it. But, you know, God told me to move on to bigger and better things. So I went into population health nursing, where I was educating patients post-discharge, as well as when they were getting admitted to the hospital. I was the one that was pretty much ensuring that their care was well cared for. And I was working predominantly with the Medicare population. So I got a lot of the education to patients in that job. And then when I realized that how much I loved educating new nurses and nurses in nursing school, because I was just tutoring people just on the side. It wasn't a big thing. And they were like, man, you should really keep doing this. Hi, Caroline. It's my bestie. And so I was like, wow, God, like, okay. So I went into my master's and graduated in 2021 with my master's in nursing education. And I've been doing that ever since. And I've loved it. I've taught in the BSN at a local university, both in the classroom and in the clinical setting. And then I transitioned into the healthcare agency, where I was educating upwards to 400 to 500 nurses worldwide on how to pass the NCLEX. And so I have been doing this. And then we have this ME nursing tutoring, which is our God-given business. And so I thank God for that. And this is what I do. I love it. And so you're in good hands today. So we are going to go through NGN. So before we get into the NGN question, just to give you a background on the next gen questions, the NCLEX, or NCSBN, who created the NCLEX, they go around and do research on new graduate nurses and what they need to know in order to be successful in the bedside setting, right? So when nurses were graduating from nursing school, they realized that there was a disconnect between theory, which is the classroom content stuff, and applying that theory in real life, right? Trying to save a patient's life, right? Because now that you have your RN license and you get put with a patient, you're no longer on, selecting all that apply or doing a next gen question or, doing a multiple choice. You are now literally taking care of this patient's life and ensuring that they are alive and well. So with that being said, they wanted to try to make the exam as realistic as possible. So they did updates, and they update the exam every 3 to 4 years roughly. And so the most recent update was in 2023 in April, which a lot of people flipped out about. And they included case scenarios. And I love next gen. Why? Because it's so realistic, right? You literally are applying the nursing process from beginning to end. What is the nursing process, guys? Let's go. Anybody talk to me. What's the nursing process? Put it in the chat wherever you are, whether you're on YouTube, whether you're on Facebook, or if you're directly here with me on this. What is nursing process? I'll give you about a minute. Nursing process. What is it? What is nursing process? That's a good one. Thank you for sharing, Caroline. Invite anyone and everyone, all right, guys? So don't be afraid to invite people. You can invite anyone and everyone. Everyone can learn from this. Even if you are not a nurse, you can still learn from this, all right? So the nursing process is what we call ADPI. So we start with assessment, then we go into diagnosis, planning, implementation, and then evaluation. So what the NCSBN did was they created this model. And this model is like a clinical judgment model where they say, okay, as nurses, we never want to start with implementing anything. We first need to get all of the data possible on this client before we can implement anything, because again, this is a patient's life we're talking about, right? So we want to assess them. Assessment includes different things like vital signs, lab values, medical history, signs and symptoms, right? And so these are things that are observable as well as verbal from the client, right? So we start with assessment. Once we gather all the assessment, then we move on to diagnosis, or in other words, diagnostic. So what could this be, right? What is going on with this patient? What could they possibly have that's happening with them? All right. And then once you determine that by ruling out certain things, and rule out means that you're saying, you know what, is it this or is it not this, right? So do they have a fever or do they not have a fever? Because that might be the difference between the flu versus something completely different, right? Are they having trouble breathing or are they not having trouble breathing? Is their heart rate high or is it not high? And so all these data collection, their lab values, their medical history, all of the things that we pull together from the assessment will help us to kind of rule out, okay, maybe it's not this, maybe it's not that, maybe it is this. Then once we determine what we think it might be, again, as nurses, we do not diagnose. Doctors do that. We have our own way of diagnosing, kind of like just knowing that, okay, it might be this disease process happening here, but we cannot give the official diagnosis. That's for the healthcare provider to determine, right? So whether it's a doctor or MP, PA, etc. So then we move on to planning. So based off of the assessment we gathered, based off of the possible diagnosis this could be, what am I going to do about it? So this is the part where this is before we even do anything on the patient physically or whatever, right? So we don't want to jump to implement anything. We want to set a plan in place first, right? So if the patient is on a blood thinner and let's say they're having pain and I want to give them ibuprofen, I'm going to be like, whoa, maybe ibuprofen wouldn't be the best option here because they're on this blood thinner, right? So if they're on this blood thinner, ibuprofen is going to thin their blood even more and put them at risk for bleeding. So you know what? Let me not do that. Let me instead maybe consider something like Tylenol, acetaminophen, right? Or Dilaudid or morphine or whatever, something that's not a NSAID, right? Because NSAIDs increase your risk of bleeding. So that's that planning process where you're thinking, what am I going to anticipate to do for this client? And what orders am I going to anticipate the doctor to order or the nurse practitioner to order? Then we move on to the actual implementation. So we actually do it, right? So we give the pain med, we do give the Tylenol or whatever, right? We put the oxygen on, we, go and take them to, to the OR, whatever, right? So we do the actual implementation for that client, that intervention, we intervene. Then we evaluate. At the end of the day, I need to know, did it work? Is this patient alive? Are they well? Right? So once I determine, okay, this is what I'm going to do, and I do it, I need to now ask the question, did they get better? Are they the same? Or are they worse? This is that part of the NCLEX that some people struggle with. So between being able to assess the client and gather information, as well as evaluating the client, that's trends, right? You want to look at the trend. So where they started, let's say they had high blood pressure and the intervention was that we are going to give them a blood pressure medication to bring down that blood pressure. Well, when you're evaluating, you want to check for, did that blood pressure come down, right? So this is where the case scenarios stemmed from. So they give you a scenario of a client and they walk you through each step of the nursing process to see, can you save a patient's life? If you were at the bedside, would you know what to do in this scenario or in this situation? All right. So with that being said, we're going to go ahead and jump into the question, and I'm going to go ahead and share my screen. Okay. Yeah, I think I'm going to have to do that just for time's sake. All right. So here we go. We are going to go ahead and jump into the question, and I'm going to read it. Please, I would love participation, whether you are in nursing school or not. Please participate. This is for everyone. All right. So here we go. It says here that the nurse is in a emergency department and cares for a 68-year-old male client. So one of the things I always say is to my clients is that I want you to make sure that you are going through each of the tabs. Okay. So this is what we called a case scenario where it flows through. So this is kind of taking you through the nursing process. That's why I picked this one to begin with, because I want you guys to be able to see here how to use the nursing process every step of the way. So here we have a 68-year-old male client that we're taking care of. All right. And one of the things I have found with these next gen questions is that they're always looking to see if you know how to identify the major issues that require immediate action, because it can lead to the patient's deterioration. So we want to try to save this life. That's how I want you guys to think of it. I'm trying to save a life here. All right. So we always open every tab and read through everything and gather all the information. So if you have a pen and paper with you or a phone or whatever to write down, I want you to write down as I go through and read this step by step so that you guys can get the information and see if you can identify things that are very urgent. Okay. So the other thing I want to put out here is that NCLEX will never tell you right away what the client has. You usually, in these type of questions, where it gives you 5 to 6 items in one scenario, they will typically tell you the answer after a few questions are answered. Okay, so they're never going to tell you like right away. So you have to be able to quickly and identify the signs and symptoms and anything else that stands out from your assessment that really is a key finding for certain disorders. Okay, so let's go through and let's talk about what we think this is. A 68-year-old in the H&P male client presents to the emergency department with intermittent substernal chest pain during activity that began yesterday evening and has worsened this morning. Okay, I want you to write down anything that sticks out to you in that first sentence. The client describes the pain as heavy pressure that radiates to his neck and jaw. Now, anytime you talk about pain, you always want to ask yourself, how is the pain presenting? Is this an expected pain or is this an unexpected pain? And one of the tips or tricks that I like to tell people is if the pain moves, we have a problem. So if the pain radiates, typically that's an emergency situation. All right. So in this case, the pain is moving, not good. It's going from the neck to the jaw. All right. We have a problem. All right. And it says it's heavy pressure. All right. He rates his chest pain a 7 out of 10. Now, you guys know that a pain of 7 and higher is pretty severe. Okay. So this pain is pretty severe for this client. He states that the pain was previously relieved by rest, but is now more persistent. Anytime something would be alleviated before, but now it's not working, red flag. Okay, red flag. You never want something that used to be taken care of and now it's no longer being taken care of. It's persisting. The client reports that he took three nitrile tablets sublingual, so under the tongue, in the past hour. Right. So if you guys remember, we usually recommend taking the nitrile, you take it like you can take up to 3. But if it goes past that, you need to call 911. All right. Hello, Catalina. Welcome. So this is interactive. I do want to see participation. So please join us in this. All right. So it says here that he did not, that it was partially relieved. So the pain was partially relieved by the 3 nitros, partially. So that means that the nitro did not do its full job. So if the patient takes nitro and they're still not alleviated, we have a problem, okay? And I want you to start thinking, why is the patient taking nitro, right? Critical thinking here, guys. Start putting your nursing caps on, all right? So here we go. He denies fever or chills. So, okay, we can't say this is an infection because it says that he denies fever and chills. So we can't say that this is an infection. Client has, here we go, history of chronic stable angina or chronic stable chest pain, hypertension, coronary artery disease, osteoarthritis, and type 2 diabetes. Wow, this is a clinical, like, perfect scenario of all the things you don't want in your client, okay? We know a disaster is brewing at this point with this type of client. He is a former smoker, no, and smoked 1 pack per day for 20 years. My goodness. He appears anxious and diaphoretic. All right. S1 and S2 is present. That's good, right? We always want a S1 and S2 heart sounds, right? Lung sounds are clear. So we know this is not a respiratory issue happening here. All right. Capillary refill, less than 3 seconds in all extremities. That's normal. That means that blood perfusion to the extremities is occurring. So we're not too concerned about that. So great. So right off the bat, I want you guys to tell me right away, what are some red flags in this scenario? What are some red flags in this scenario? Just drop it in the chat. What are the red flags that you're like, whoa, 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 this is not good? Let me know. And again, you don't have to be a nurse, okay? So this is fun. I want this to be interactive. I want you guys to participate. Red flags that automatically stick out to you and you're like, uh-oh, no bueno, no bueno. Pa bon, for my Creole people, right? And I'm going to be monitoring the chat making sure, and I will call out some people. Jasmine, Caroline, Cassie, Catalina, tell me what sticks out to you? What are some red flags? What are some red flags? Oh, Stephen, hi. Aw, hi, Stephen. Chest pain, I agree. Chest pain is a red flag. Absolutely. Chest pain is definitely a red flag. Anyone else? Ooh, Jasmine, be more specific. What about the pain? Be more specific about the pain. But yes, the diaphoresis is a red flag, right? What else? What else is a red flag? So we don't have a temperature just yet. So we'll get to that in a second. We just want to focus on the history and physical first to see what in the history and physical is concerning, right? What is concerning just based off of what we read here together? What do you think is concerning? Ooh, radiating pain. That radiating pain is concerning. Absolutely. Let's point out some other things here. So let's talk about the history for a second. This client has chronic stable angina, right? So that history of coronary artery disease, which is plaque buildup in the coronary arteries, coronary being heart, artery, right? The vessels. So the heart vessels are clogged, okay? Hence why the client has chronic stable angina or chronic stable chest pain. When you have clogged arteries, I want you to think about it, right? If you have this water bottle, right? This water bottle is open, right? It, water comes in and out easily, no problem, right? And remember, your blood, which the water is representing the blood here, your blood has oxygen in it, okay? So as blood flows in and out, you're giving oxygen to your tissues. Well, when you start to clog or cut off at least half of that surface area because of plaque buildup, right? Guess what happens now? What starts to happen now is you're not getting as much oxygen because you're not getting as much blood flowing through. So guess what? The tissues which were getting 100% oxygen are now getting 50% oxygen, or they're getting 70 or 60% oxygen when it should have been 100%. So anytime you start to feel or your body starts to sense that there's a lack of blood perfusion or a lack of oxygenation, your tissues start to become ischemic, or they start to become injured. And so you feel that pain. So that's why he had pain, right? It was a chronic chest pain that he felt. But the reason why it's considered stable is because the plaque didn't break off. At least not yet, right? The plaque didn't break off. So the nitro would typically alleviate it. So if the chest pain is alleviated by the nitroglycerin tablets, which we know that nitro dilates those blood vessels, right? So that your blood vessels can open up more so that more blood can flow through and more oxygen can flow through, which means that your tissues you can prevent tissue damage from the lack of oxygen and perfusion of blood. Then we call that stable, right? Because the pain goes away. But now the nitro's not working as good as it used to. So at this point, we have to say now or recognize now that he's no longer in a stable angina state now. Hypertension also increases the risk of vessel damage. And if you have plaque buildup and you have high pressure, I want you to think of like if you had a plate and a plate full of, food just sitting there, right? You're going to turn on your water faucet. You're going to blast it so you can get all that gunk removed off the plate, right? Well, guess what? That's what's happening in your blood vessel. The pressure is breaking off that plaque. That plaque is now traveling through the body, essentially like a blood clot, right? Or a clot, and it gets stuck. And now when it gets stuck in that vessel, now you have no perfusion happening because guess what? You're blocking traffic. So now let's just say, they cut off all lanes. All lanes are blocked, right? Because of a big accident. That clot is that big accident where there's no movement, okay? There's no movement of blood to get to the other side. So when that is lacking oxygen, now all the tissues in that area start to die off. And now you have pain. Okay, so the type 2 diabetes also puts you at risk. If your blood sugar in your body is not regulated properly, the excess amount of sugar in your blood vessel starts to, your blood starts to coagulate, starts to get thick and sticky, and then starts to create plaque buildup. That plaque buildup increases your pressure, right? So think of like a water hose. If you are holding a water hose, the water comes out normal, comes out freely. But then if you step on the water hose, guess what? That pressure increases, but it's less water coming out, even though the pressure increases. Well, that's what happens with type 2 diabetes and hypertension and coronary artery disease, right? Now, we can say what came first, the chicken or the egg? We don't know, right? We don't know if the diabetes caused the coronary artery disease, which led to the hypertension. We don't know if the hypertension, caused the, type 2 diabetes. We don't know, okay? We don't know. But what we do know is that he has key indicators for high risk of an emergency life-threatening situation to occur. It didn't tell you what it was, though, and I'm not going to say it just yet. Smoking. We know that his history of smoking increases the risk of coronary artery disease because smoking thickens your blood and increases plaque buildup in your arteries and your vessels. So this client, thankfully, is a former smoker, but unfortunately for this client, they already had damage to the vessels for 20 years from 20 years of smoking. All right. So now they're feeling all these different signs and symptoms. Okay. So now let's go through the vital signs. So we have here the substernal chest pain. It's getting worse. We never want pain to get worse. The pain is radiating. Okay. The pain is severe, 7 out of 10. It's not alleviated by the nitro. Okay. And the client has all this medical history, and then they're diaphoretic. So based off of all these things, what diagnosis do you think this client has? What do you think this client has so far? Like, if you were to think, what is something that comes to mind in your brain, like just off of the history and physical, just based off of this little paragraph here, what comes to mind? And I am monitoring the chat. I want this to be interactive. I want us to have fun. What's coming to mind? Jasmine, Catalina, Stephen. What do you think is coming to mind? Ah, I like it, Jasmine. I like where you're going with this. Yeah, this probably could be a MI, a myocardial infarction, right? A heart attack. This could possibly be a heart attack. All right, so let's look at the vital signs. Thank you for that. So temperature is 36.8 Celsius, so 98.2 Fahrenheit. Usually we don't consider anything a fever if it's less than 100.4. So this client does not have a fever, so we can't say this is an infection. The pulse is 105. Would we consider this to be tachycardic? Yes, because normal heart rate is 60 to 100. Anything above 100 is considered tachycardic. Now the question becomes, well, 105 is not that serious. Well, in the setting where this client is presenting cardiovascular symptoms, it is concerning that their heart is tachycardic. Okay, respiratory is usually 12 to 20, but in this case it's 21. So we do see that there's a little bit of compensation happening, right? The body is sensing that there's a lack of perfusion, a lack of oxygen happening somewhere. So the respiratory rate tries to accommodate by breathing in faster, so you could take in more oxygen quicker, right? So you breathe faster because your body senses that there's a decrease in oxygen within the blood, okay? So they are tachypnic, all right? And I'm using these words because NCLEX can use any of these words. They could say tachycardic, they could say rapid heart rate, right? So I'm trying to give you guys the terminology so that you can begin to also speak like a nurse. So you not only think like a nurse, but speak like a nurse, right? Blood pressure is 115/83. That's a normal blood pressure. Usually we want the blood pressure, the systolic, which is the first number or the top number. We want it to be about 110, between 100 to 120. We don't really want it to be too high. And then the diastolic, which is the next number or the bottom number, usually we want it to be about 60 to 80, right? 85, etc. So this is not too bad. Pulse ox is 96. We know that normal pulse ox is about 95 to 100. So they are within normal range in this case. So the two things that stick out is that pulse and that respiratory, okay? Although not super high, still on the high end. So now let's go to this. Look at this right here, guys. EKG. Here's the ECG for this client. Based off of this ECG, I want you to tell me, what kind of ECG is this? What ECG is this? This is a nurse's nightmare, okay? If I could put it that way, this is a nightmare for a nurse, okay? If you see this, you're like, oh Lord, right? Help them, Jesus, all right? And you better be doing what you got to do, okay? This is a nurse's nightmare and a patient's nightmare and a doctor's nightmare. It's everybody's nightmare. What kind of ECG is this? Okay, what do we consider this? Put it in the chat. Anybody know what this ECG or AKG is? So if you are thinking that this is a ST elevation, or in other words, STEMI, right? So ST elevation myocardial infarction, you would be correct, okay? Here's the labs, okay? So the nice thing about NCLEX that came with the updates from 2023's change is that they now provide you the ranges for lab values. When I was in nursing school, I had to memorize this, okay? So definitely a blessing, because technically in the real world in nursing, they give you the ranges because every hospital is different with their ranges. And so in that case, you want to go ahead and change that, because in real life, we're given the ranges. We don't have to memorize it in the hospital. But what you do need to know is, what do these values mean if it's low or high? That they won't tell you. So sodium is 142, range is 136 to 145. This is a normal range. 3.5 to 5 for potassium, they are 4.5, normal. BUN, blood urea nitrogen, is 10 to 20. In this case, theirs is 15, all normal. So if everything's within normal range, we're not going to be concerned about their lab values, okay? So we're going to move on to the next lab values. Here we go. We have that creatinine, 1.2. All right, this is a male, so his range is 0.6 to 1.2. He's within that range. We're not concerned about kidneys right now because we know creatinine correlates to kidneys. Look at that glucose, 195. But remember, are we going to be concerned about a 195 glucose? No. You know why? Because he has a history of type 2 diabetes. So this is not concerning at this point, and that's not the most pressing issue here, okay? This 195 is not going to kill the patient, okay? Now the complications of uncontrolled diabetes or blood sugar can kill the patient, but right now that 195 is not going to kill the patient, okay? Now, if he was hypoglycemic, then we got a problem, okay? Troponin should be less than 0.03. They are 2.5. That is a high troponin. All right, so this is a positive result, which is not good. What does troponin mean? What is troponin? What is the point of troponin? If you were to put together that EKG or ECG with the troponin, this is a classic sign of what? And also with all his signs and symptoms that he presented with. What is this a classic sign of? What is this a classic sign of? What do you guys think this is a classic sign of? If you're thinking myocardial infarction, you would be correct. We know that myocardial infarction is a life-threatening condition. All right, guys. So now that we've gathered all the information, we went through the assessment, Now we're going to ask the question, and we're going to move on to the right side of the screen, which says, which client's findings require immediate follow-up by the nurse? Now, anytime you see the word immediate, it means that this patient can deteriorate very fast. All right. So in this case, with this client, we want to find things that are pressing. Okay. So you want to focus on what is pressing, what is like so concerning that I need to address it right now. Like I cannot wait. Okay. So we're going to go through each one together. All right. So I'm starting with the vital signs tab because the first two are based off of the vitals. Okay. So pulse. Now, again, although the pulse is tachycardic, the question becomes, am I concerned about 105 pulse rate? Is this going to kill the patient? Is this going to, cause, the patient to deteriorate faster? I would say let's hold that. Okay. I'd say hold off on that one. Let's move to the next one. Respirations is 21. That 21 is not too significant, right? Yes, it's slightly elevated by one extra respiratory rate, but it's trying to compensate for what's happening in the patient's body. So in this case, we're not going to pick respirations because their O2 sat, when you look at it, is normal, right? Their O2 sat is 96. So I'm not concerned about that respiratory rate. I expect that to be tachypnic, right? So we're not going to select respirations. Now let's go to the lab values, right? Troponin. That troponin is elevated. Are we concerned about that troponin? Absolutely, we are concerned about that troponin, right? Because that troponin is a clear, direct indicator of a myocardial infarction happening, or ischemia. Something is going on with the patient's heart muscles. There is death to the tissues, okay? Pain. Is that pain concerning? It's radiating from the neck to the jaw. It's heavy pressure. It's a 7 out of 10, right? Yes, I am concerned about that because that is telling me that this is an MI. This is a clear pain that is correlated to an MI. Past medical history. Now, I'm going to be honest with you guys. This one tends to be I call it a distractor. If the patient's past medical history is not a current issue right now, you're not going to select it. And in this case, their past medical history is not an issue. Their blood pressure is not elevated. All right. They no longer have stable angina. All right. Now they're definitely unstable now based off of the ECG that we just saw. Osteoarthritis has nothing to do with the cardiac history or cardiac situation going on here. And that type 2 diabetes is not crazy, right? We expect it to be somewhat elevated because they're diabetic, right? So we're not concerned about that past medical history. It's not really going to help us. And that past medical history is not going to kill the patient, right? They have an acute issue. You're looking for acute findings. Their past medical history is not an acute finding. Their response to nitro. Anytime someone is not responding to nitro, we have a problem here, okay? So the fact that the client took 3 nitros and the pain still is a 7 and it's radiating, that means that the nitro is no longer working. That means that occlusion in the blood vessel is now very occluded. Because in order for nitro to be effective, it needs to be able to dilate the vessels large enough that that the body doesn't sense that there's some ischemia happening. But in this case, the plaque is so large that even when the vessels are trying to dilate, the plaque is still causing too much blockage. So that response to that nitro is concerning, right? The fact that they're not responding to it the way they should. It's not removing the pain. And then lastly, and everybody better say this, that ECG is a nightmare. All right. You see that here, that ST elevation, right? So you see you have the P wave right there. And look at that. That S and the T are elevated. All right. The S is right here, that notch, that T is up here, and it's coming back down. That's a ST elevation. We don't like that. This patient is in a life-threatening emergency. So we're going to go back to that pulse rate real quick. And we're gonna ask ourselves, am I super concerned about that pulse rate? No. So we're gonna move on. So if you selected in your mind 3, 4, 6, and 7, so troponin, pain, the response to nitro, and electrocardiogram findings, you were correct. Okay? You were correct. All right, so now let's move on. Now, anytime you move on to the next question, you never want to answer a question without first verifying that there's no new information in each of the tabs. So this is the same. So we're going to move on. This is the same from the first question. This is the same. Labs are still the same. Labs are still the same. So there's nothing new in each of the tabs. So now we can move on to the right side and answer the question. It says here, complete the following sentences by choosing from the list of options. All right. The client is potentially experiencing what? Chronic stable angina, an ST elevation myocardial infarction, or a non-ST elevation myocardial infarction. In order to rule out, we want to first start by asking the question. Chronic stable angina. Remember what I told you at the beginning. In order for chronic stable angina to be still chronic stable angina, that means that nitro has to work or that the chest pain is alleviated. In this case, he said it's not alleviated. He still has the pain. The nitro is no longer working. The pain is getting worse. All right. So in this case, they are no longer in stable angina. They are now in unstable. So we rule that out. So now it's between ST and non-ST elevation. Well, in order for us to know, we have to look back at the ECG. This requires you to know how to read an ECG on the NCLEX, because NCLEX will ask you rhythms. Okay. So in this case, this client right here, in order for it to be a non-ST elevation, they have to have normal, like this one right here, they have to have a normal EKG. Okay. In this case, or an inverted T wave or something, right? But if the S and the T wave are both elevated, like in this case right here, okay, if it's elevated, this is considered an ST elevation. So based off of that, we're going to select an ST elevation. This suspicion is best supported by what? The key word here is best. So now we have, and this could be a tough one, right? You have serum troponin, which we know the troponin is elevated. We know troponin is directly affiliated with damage to the heart muscle, so a lack of perfusion to the heart muscle. The 12-lead ECG, and an evolving chest pain. In order for it to make sense, you have to ask yourself, what correlates an ST elevation myocardial infarction? How do I know that this is an ST elevation? Well, let me show you guys something. If this was a non-STEMI, meaning that the ST is not elevated, then you could say troponin would be the best indicator, because the ECG is not showing any changes. Or maybe there's an inverted T wave or something. But there's no, if this was a non-STEMI, you would have to go with the troponin to definitively say that they're having a heart attack, even though the ST is not elevated. The chest pain could be to anything. Anything could cause chest pain. Did you know that having gas can cause chest pain? Did you know that gastric acid reflux can cause chest pain? Did you know anxiety can cause chest pain? Did you know that the substernal pleuritis can cause chest pain? So PE can cause chest pain. So many things can cause a chest pain. That's not the best support. So the best support, the clear indicator that someone is in an ST elevation myocardial infarction, is only that ECG. The ECG is the only way for us to definitively say that this is a STEMI and not just an NSTEMI. So if it was an NSTEMI, you have to go based off of the troponin. If you see that there is elevation, then you have to say it's the ECG that gives you the best support. Okay. Boom. Best support. Okay. So now we're going to go through again and make sure that all of our tabs don't have anything new. So still have the same history and physicals, still the same vitals, still the same ECGs, same lab, same lab. Okay, so nothing's changed, okay? So now we're going to move on to the select two complications the nurse is most concerned about the client developing. So remember, when the client has an MI, especially when it's a STEMI, what is happening to the heart muscle? Can anyone tell me what is happening to the heart muscle? What's happening to the heart muscle? What's happening to the heart muscle is that there's a lack of perfusion. That lack of perfusion is causing a lack of oxygen. And that lack of, and the only way for oxygen to travel is through blood. And the only way for blood to travel is that there has to be an open, highways is what I like to call it. I like to think of blood vessels as the highway. So if the highways are blocked, you got traffic, you got backup, right? You're backed up. You can't move. You can't get anywhere. And who loves traffic? I don't know anybody that says, yay, traffic. Never, right? The same is with your heart or any part of your body. Anytime you have a blockage of movement for blood, you are now in a position where there is complications and tissue death can occur. We never want blockages. So in this case, the tissues are dying. So if the tissues are dying, right, then you have to ask yourself, well, can the heart function then? What's the purpose of the heart? The purpose of the heart is to pump blood. The heart is what moves the blood. The heart is what moves blood. So if the heart muscles are dying, can the heart properly pump and move blood throughout the body? Can that happen? Can the blood move properly? If you said no, you're correct. If my pump doesn't work, blood doesn't move. And if blood doesn't move, oxygen doesn't move. Okay? So now let's go through it. We are most concerned about. So it doesn't mean that there isn't anything else that could potentially happen. It's just these are the highest risk of happening, okay? So two of them are the highest risk of happening. So let's start out. Pericarditis. In order for pericarditis to occur, typically pericarditis is caused by an increase of fluid in the pericardial sac. Well, in order for that to happen, typically it's caused by infection or trauma. In this case, the client didn't have any infection or trauma happening, so we can't say that this is pericarditis. The next one is heart failure. What is heart failure? It's the heart's inability to properly pump blood. What did we say about heart muscle? If the heart muscle is dying, the heart can't pump. So that sounds like a pretty concerning condition and it's very likely to happen. So we're going to hold that one. Acute kidney injury. When does acute kidney injury happen? Well, in order for the kidneys to function properly, blood has to get to the kidneys. But in order for blood to get to the kidneys, the heart has to pump properly, right? So, and there has to be enough fluid in the body to get to the kidneys. So this is a very likely case that the patient might develop acute kidney injury. The difference between acute and chronic kidney injury is that acute kidney injury is caused by lack of perfusion or low pressure, right? And then chronic kidney injury is typically caused by high, continuous, chronic pressure in the kidneys. So usually hypertension, for example. So in this case, this is not something that's chronic, right? So acute is more likely in this case because, again, the heart muscle is dying. But so we're going to hold that one, okay? So heart failure and acute kidney injury, we're going to hold. Ventricular arrhythmias. Where is the heart's conduction? The heart's conduction is in the muscles, right? So you have the SA node, the AV node, the Purkinje fibers, right? We learned all about that in nursing school, right? So yes, it is concerning, Jasmine. So ventricular arrhythmias, sometimes that happens because there's a lack of something. So if the tissues in that area are dying, will it be able to perfuse the electrical conduction site? No, it won't be able to perfuse the electrical conduction site. And depending on where the MI is occurring, if it's ventricular, we know that the ventricles are what are the main ones that cause perfusion throughout the body, because it's the main pumping mechanism or the main pumping site to go to the blood. Okay, I mean, to go to the body. So if the ventricles are not able to pump, we have a problem. The body's not getting blood. And if the body's not getting blood, patients can die. So we're going to hold that one, right? Because in order for the heart to function properly, the tissues have to be healthy and getting oxygenated, and that keeps a healthy electrical conduction. Okay, but if there's no perfusion, then that can cause death, tissue death. And then last one is abdominal aortic aneurysm. Okay, so we know that aneurysms are usually caused by high pressure over a long period of time. Essentially, it's almost like the vessels are ballooning. So they're no longer elastic. Blood vessels are elastic. They're kind of like a rubber band. They can expand and recoil very easily, right? But you don't want it to overexpand, because then it could pop, right? Just like a rubber band. If you pull a rubber band hard enough, it's going to pop. If you blow a balloon large enough, it can pop, right? Because the elasticity is overstretched. Well, in this scenario, that's not the most concerning thing here, because their blood pressure is actually normal. Their blood pressure is 115/83, if you remember from the vital signs. So we know that it can't be pericarditis, and it can't be a AAA or abdominal aortic aneurysm. So we're going to eliminate 1 and 5. So now we're down to 3 options, but we want to pick the most concerning out of the 3, which is 2 of the most concerning out of the 3. And what I will tell you is, if the issue is the heart, that's going to be the most concerning. The kidneys is not in the heart, but heart failure and ventricular arrhythmias directly affect the heart. And they both correlate to a lack of perfusion and tissue death. So not only do you have a mechanical malfunction because of the tissue death in the heart, you also have an electrical malfunction, because remember, the heart is mechanical and electrical. You need electrical conduction to generate a pulse to then cause the heart to pump mechanically, right? So you can have failure of both your mechanical and your electrical conduction of the heart. So the most concerning of the 3, we're going to say, is heart failure and ventricular arrhythmias. Now, this doesn't mean that they're not at risk for AKI or acute kidney injury. They are at risk for an acute kidney injury, but it's not most concerning compared to heart failure and ventricular arrhythmias. All right. Why? Because again, this is directly affecting the heart, and tissue death can cause this. And remember, if they have a ventricular arrhythmia, that's either ventricular tachycardia and ventricular fibrillation. They're at risk for those 2. And we know that those 2 are deadly. Those are your lethal rhythms, is what we call them. Okay. And you would be correct if you selected 2 and 4. Great job, Jasmine. Go ahead, girl. Look at my nurse. Go ahead, Jasmine. RN, let's go. Okay. So now we went through the assessment. We went through the planning. And now we're in the intervention section. Okay. So this is the planning and intervention. Okay. We went through assessment and diagnosis. I apologize. We went through assessment and diagnosis. Now we're in that planning and implementation phase now, right? This is what we're getting into now, right? So let me know in the chat if this is helping, if you feel like your critical thinking is building here, okay? Please let me know how it's going. If you're enjoying this, let me know if this is making sense, all right? Let me know, all right? Now, here we go. We're going to check all the tabs, like I said before. Nothing new, nothing new, nothing new, nothing new. So now we're going to move on. We're going to move on to the right side of the screen, which is the question, okay? So for each potential nursing intervention, click to specify whether the intervention is indicated or not indicated for care of this client, okay? So we want to know, do we need to do this intervention for this client? So indicated means yes, you want to do this. Not indicated means no, I don't want to do this, okay? So let's go through it. Administer ticagrelor. Guys, I can't say it. I'm sorry. Ticagrelor, whatever. What kind of medication is this? What kind of medication is ticagrelor? Ticagrelor. I wish I could say that properly. Ticagrelor. Hurts my mouth to say it. What kind of medication is this? If you're thinking an antiplatelet, you would be correct. This is an antiplatelet, okay? Anytime someone has a clot in their heart, we typically like to give them an antiplatelet to prevent platelet aggregation. So in this case, yes, this would be indicated for this client, okay? Then it says continuous cardiac monitoring. Well, look at that ECG. Do you want to continue to monitor this client to make sure that that ST elevation goes down and it's not getting worse, or that they don't go into a ventricular rhythm, a lethal rhythm? Yes, you want to make sure you're checking on that, okay? Ticagrelor. Yep, nope. I'm saying it in my head, but I can't say it out loud. Aspirin. What is aspirin? Aspirin is also an antiplatelet, right? So it also helps with thinning out the blood and preventing blood clot. Usually when we have a client who is actively having a heart attack, we want to usually give both something of an antiplatelet as well as aspirin, okay? Aspirin is absolutely necessary, and we want to give a high dose of aspirin, not a low dose. We want a high dose of aspirin, okay? So do we want to administer the aspirin crushed PO? Yes, that's indicated. You want to give aspirin. And yes, you can crush it, okay? Now, IV nitro. Do you want to give them nitroglycerin IV? What is nitro? Nitro is a dilator, a vasodilator. Okay, it dilates. It's a potent vasodilator to open up the blood vessels so that that plaque is no longer preventing the blood from moving, right? It helps to cause the blood to flow in through the vessels more smoothly, and to open it up. It's kind of like when there's traffic and they finally open up a lane, right? That helps to get the traffic moving. If you have a 3-laner and only one lane is going, you open up one more lane, that helps to reduce traffic, right? Get traffic moving better. So it's the same with nitro. Nitro helps to dilate those vessels. So anytime, as long as this is not an inferior wall MI, and due to time, I can't get into that. Because this is not an inferior wall MI, we are going to say, yes, it is not contraindicated for this client. Therefore, we can give nitro IV. And their blood pressure is also normal. Remember, one of the downsides of nitro is that it drops your blood pressure. So the patient has to have a normal blood pressure before you can administer nitro. If their systolic blood pressure drops below 100, you're going to hold that medication and call the doctor. Okay. In this case, they have a normal blood pressure. We can go ahead and give them that IV nitro. Regularly assess peripheral pulses and capillary refill. Do you want to regularly assess that peripheral pulse and capillary refill? Of course you do. This gives you an indication of how well the heart is perfusing. Is blood getting to the rest of the body, right? Or And then also, this is also to ensure that the client is not bleeding because they're getting that, the aspirin and the ticagrelor, right? So because of that, we want to check that capillary refill, because capillary refill tells us if they're perfusing or not perfusing appropriately, okay? Assess the client's exercise tolerance with a walk test. Now, this client is actively having a STEMI. Do you want them to exert any energy? Do you want their heart to increase in oxygen demand? Because exercise causes increase in oxygen demand. No, you want their heart to rest. You don't want to cause any more demand on the heart. So with that, we're going to say, no, this is not indicated. The client is not stable for me to be able to get them up and walking and moving. Okay. We don't want to do that. We don't want to exert this client more than they need to be exerted. And then lastly, administer 2 liters of oxygen via nasal cannula. Is this client's oxygen sat low? No, their oxygen sat is normal. And remember, now they say that oxygen is considered a medication. So you have to have an order for it. And there is a risk for patients developing oxygen toxicity. So if the patient is perfusing properly and their oxygen sat is okay, we're probably not going to need to give them oxygen right at this time. Now, back in the day, that was different. We used to put oxygen on people regardless if their O2 sat is normal or not. But recent studies have shown that it's probably best not to. Okay, so if you said no to 6 and 7 and yes to 1 through 5, you would be correct. Okay. So again, we want to make sure that we're not giving that patient extra oxygen unnecessarily. All right, guys, almost done. Let me know if this is helpful. Let me know if you're learning, okay? I want to know. Please let me know. I want to make sure that I'm providing you something useful and helpful. All right? So here we go. Checking all the tabs again. Vital signs. Oh, look, a new thing popped up. This is important, okay? So this is why you always check, because the new information is going to determine what you do next. So 12 o'clock, their temp is 36.7, 98. That's not a fever. That's perfect. Heart rate is now 93. Beautiful. It's no longer tachycardic. Respiratory rate is now normal at 18. Blood pressure is still stable and holding at 110/75. And that oxygen sat is still within normal range at 95% on room air. No new diagnostics here. No new labs there. No new labs there. But look here, a progress note. Day 1 at 12 o'clock, client received the loading dose, so there's a ticagrelor and an aspirin, was placed on an IV nitro. The client was transferred to the cardiac catheterization lab where they underwent the PCI, also known as percutaneous coronary intervention, through the femoral artery approach. So this is where they put a catheter through the femoral artery near the groin, okay, and they trace it all. They follow that artery all the way up to the heart and go into the area of wherever the artery is blocked, and they put what we call a drug-eluting stent. So a stent that opens up that blood vessel and moves it pushes the plaque to the side to keep that blood vessel open. Okay, so they put it into they had an LAD. We call that the widowmaker. Okay, so this patient had a true major heart attack. They could have died from this. So they placed a drug-eluting stent in the LAD, the left anterior descending coronary artery. All right, so that is a major artery in the heart, and it's big. And because of time, I can't show you the pictures. Okay, but this is important. Okay, so that drug-eluting stent, what it does is that the stent releases medication to prevent reocclusion, to prevent plaque buildup in that area again. And then the client got transferred to the coronary care unit in stable condition. So the client is now stable after that procedure was done. Okay, so now let's move on to the question. It says here the nurse reviews the client's progress report, notes, and updated vitals from 12 o'clock. The nurse is in the coronary unit and is caring for the client immediately after the stent placement. Drag the potential interventions the nurse should take to the box on the right. Choose only the interventions that are appropriate. So we don't want potential interventions in terms of, potential means that if it happens, then we'll do it. But what it wants to know is, what are you going to do right now? Okay. So in this case, we want to ask ourselves, what are the things we're going to do right this second after the patient has had a drug-eluting stent placed through the femoral artery approach? Okay. So let's go. Do we want to encourage oral fluids? Yes. Okay. You do want to encourage oral fluid intake, right? You want to increase fluid intake so that the patient can continue to maintain their blood pressure, get that blood flowing, okay, to help their heart, okay? Especially with everything that's happening after the surgery, right? Because, they use a lot of medication and sometimes some dye and things like that. So they want to get that out of their system. So you want to increase their oral intake. Metoprolol is a what, guys? What kind of medication is that? What kind of medication is metoprolol? If you said it's a beta blocker, you would be correct. We typically give beta blockers to clients after an MI to help their heart not pump so hard and to reduce that oxygen demand, myocardial oxygen demand, okay? So it helps to keep their blood pressure stable, helps to keep their heart rate stable so that their heart is not overexerting itself, especially after it just recovered from an injury, all right? Because the STEMI is caused injury and ischemia. Monitor the site for bleeding. Yeah, you definitely want to monitor that site for bleeding because guess what? That femoral artery is a major artery with high pressure. And because the client is on all those blood thinners like that ticagrelor, as well as the aspirin, and they're getting a drug-eluting stent, they're at risk for bleeding after that artery after that artery approach, right? So we want to make sure that this patient doesn't continue to bleed, all right? We usually keep the patient's legs stable and we don't let them move their leg for 6 to 8 hours. And so in that case, you do want to keep that affected extremity extended. You don't want them to bend that leg because it can cause them to bleed, all right? You want to keep it stable. And they usually put a pressure dressing on the puncture site where the femoral artery was punctured. Now, the last one that we have is assess the dorsalis every 15 minutes. Now, the reason why we probably wouldn't consider this, even though it sounds good, is because when you're assessing the dorsalis, there's assumption that the patient is actually bleeding. In this case, nowhere did it indicate that the patient is bleeding. Therefore, I don't need to assess that dorsalis every 15 minutes. All right. And then it says apply pressure above the puncture site if a swollen, indurated area develops. This is only necessary if it happens. So if it's not happening, we're not going to do it, right? You're not going to just put pressure on somebody's, put pressure on somebody right this instant when it's not something that's occurring. It says that the client is stable and that they didn't have any issues after they had the stent placed. Therefore, we're going to keep that in the potential interventions. We might do it if they do start bleeding, but we don't need to do that right this second. So therefore, as you can see, right, here we go. So the client this is not something we need to do right this second. All right. And then lastly, here we go. So we're going to go through it again. Okay, nothing new, nothing new, nothing new, nothing new. All right. Oh, wait, there is something new. You see there? Day 2, 8 o'clock. So 8 a.m. the next day, client's vital signs were stable overnight. They had no further chest pain. That's great. On the cardiac monitor, they had no arrhythmias. That's great. They are now stable for discharge, and they have a plan to follow up with their cardiologist in a week, or the cardiology clinic in a week. So this client's ready for discharge. So one of the things that we nurses do at all times is we always, always, always educate. All right. So here we go. We're going to evaluate if the client understood our education. So it says here, nurse reviews the day 2, 8 o'clock progress notes. The nurses in the coronary unit has provided discharge teaching to the client. Which of the following client statements indicate that the teaching was effective? Okay, so what was effective? All right, so let's go through it. I will continue to take both aspirin and ticagrelor after I am discharged from the hospital. Yes, that is correct, because the client is still at an increased risk of re-occluding. So you want them to continue that medication even after they had the stent placed, okay? Because we don't want them to re-occlude. Here we go. I mentioned this earlier at the beginning of this session. I can take naproxen or ibuprofen if I have aches or pains in my joints from physical activity. Now, remember what I told you. Naproxen and ibuprofen are considered what? If you're thinking NSAIDs, you're correct. An NSAID is a non-steroidal, right, medication. And that medication can cause thinning of the blood. So if the blood is being thinned, do we want them to be on aspirin, ticagrelor, and now a pain med that thins their blood? No, they're at an increased risk of bleeding. We don't want this client to bleed out on us. So guess what? We're not going to select number 2 because that can increase their risk of bleeding. If I fall and hurt my head or hurt myself, or if I hit my head, I should contact my healthcare provider immediately. Yes. Why? Because they are on aspirin and ticagrelor. All right. I'm going to just call this Tica because I don't know how to say this. Okay. So they're on Tica and aspirin. Okay. So because they're on Tica and aspirin, they need to call that healthcare provider immediately because they could develop a brain bleed. All right. I should slowly increase my activity level to a goal of 30 to 60 minutes of brisk walking at least 5 days a week. Yes. Remember what I said. You want that heart to not have too much overuse. Okay. You don't want to increase that cardiac demand too much, but you want to slowly break that client in because, again, as the heart begins to heal, you want the heart to begin to work again. And studies have found, evidence-based research has found that clients that go into cardiac rehab following a MI, which is like a type of exercise that they do that's specific to the heart, they have been found to heal faster and their heart and have a lot of reversible damage to their heart. So you do want them to increase their activity, but slowly. Okay. I should keep a bottle of nitro tablets available in my house and my car in case I experience chest pain again. So one of the things I always say is when you're reading through a sentence, you need to make sure that every single word in that sentence makes sense. If it doesn't make sense or if it's questionable, the whole thing is wrong. In this case, the questionable thing here is the car. The car is hot. Nitro does not work if it's in a hot environment. It becomes unstable and it becomes ineffective. So if the client has it in their car, that's not good. So in this case, we would say, no, you don't want that nitro in that car. So we're not going to select that. That's not correct. And then lastly, I can gradually resume sexual activity once I can climb 2 flights of stairs or walk a block without experiencing chest pain. Yes, they can gradually resume sexual activity. As long as they can walk 2 flights of stairs and or a block without experiencing chest pain, they can engage in sexual activity again. And yes, there is a lot of taboo things about sexual activity with patients, but this is an integral part of a patient's life. And so the ability to resume that, and it is a form of exercise for a client. So you want to make sure that their heart can tolerate it before they resume it. And so the best way for them to know is if they climb 5 flights of stairs without getting short of breath and chest pain. If they can't, they should probably wait until they are able to do so. All right. And here we go. We would be correct. All right. So that is the end of our session. I hope you guys learned a lot from this session. I appreciate you guys for joining me during this time. And I just want to give a few announcements before I let you guys go. Let me just stop presenting. So once again, thank you guys for joining. We take pride in knowing that we are helping new nurses be the best that they can be, and that starts with you passing the NCLEX. But it's not just about passing the NCLEX, it's about being able to save a life, right? So for a limited time offer, what we are offering is that the first 15 people, and we are going to break them up into small groups of 5 people, all right? And there's going to be different groups you can join at different times and different days. But we are offering group tutoring starting next month, and the first 15 people to sign up will get access to our Plus membership. That Plus membership is a group tutoring session, and what that comes with is 2 hours weekly of tutoring, all right, in a group setting. You also get access to our WhatsApp community group where you are being held accountable. You're getting motivational instructions and motivational messages each day. You also get handouts, and you also receive digital cheat sheets that is only accessible to our Plus community. You also have access to the recordings after each session. So that also gives you an advantage to go back and rewatch the recording so that if you missed something, you can go back and write it. We also offer one monthly mini assessment to give you feedback on your progress to make sure that you're on the right track before you sit for your NCLEX as well. And so for the first 15 people to email us at edmetutoring, right? So it's edmetutoring@gmail.com. E as in elephant, D as in dog, M as in Mary, E as in elephant, the word tutoring all together at gmail.com. The first 15 people to email us by September 1st and to pay by September 1st will get $50 off on that package. That package is typically $450, but if you go ahead and send us an email with the code word RN2025, you will receive $50 off on that package. So it would only be $400 instead of $450. All right, guys. Also, I just want you guys to also, if you're interested in tutoring and you want to know more, you can go on our website. And on our website, you're going to scroll down and it'll say get started. Fill out that survey, complete that survey, and we will get in touch with you and give you guidance on what your next steps will be for tutoring. So in order to fill out that form, it is edmetutoring.com. So www.edmetutoring.com. And then you scroll down until you see, and I'm going to show you guys now. You scroll down until you can see so this is the main screen, and you will scroll down until you see get started here, and you click on complete the survey. And when you go to complete the survey, you just hit start and start filling out that information. All right, you click start, put in your information, and then it'll take you to the questions. It's quick and easy. And again, just to show you guys our membership packages, once again, we have 3 packages that we offer. All right, we're giving you a discount on the Plus. The difference between the Core and the Plus is that with the Plus, you get access to the recordings. With the Core, you don't get access to the recordings, okay? So if that's something you're interested in, we are offering $50 off on the Plus group coaching, okay? So that's about $100 per week, and it's 2-hour sessions. And again, you get access to the recordings, you get digital NCLEX resources, you get 1 monthly assessment on just checking on your progress, and then we keep you accountable every step of the way to ensure that you're on track to passing your NCLEX and becoming a nurse. All right, guys, so thank you so much for joining once again. My name is Mrs. D, and once again, I am super glad you guys joined me today. I hope that you all have a wonderful rest of your day. God bless you guys, and I will see you on the next live. I hope to see you guys in tutoring group sessions starting next month. Bye, everybody.